In this course, the principles of external fixation are demonstrated using the Hoffman external fixation system. Other systems are, of course, available. The following instruments and materials are required: an orthopedic drill with drill sleeves and a universal chuck, a hand brace drill, 4 pins, also known as shunt screws. 2 of these are of medium length for insertion into the tibia, 1 is longer for insertion into the calcaneus, and 1 is shorter for insertion into the first metatarsal. 2 short rods and 2 long rods, 5 rod-to-pin clamps, 3 rod-to-rod clamps, a depth measurement tool, and instruments to tighten the clamps. The shunt screw, a front-threaded stainless steel pin, is shown here. One side is threaded and the other side is blunt and unthreaded. A rod-to-pin clamp has 2 openings, a small one for a pin and a wider one for a rod. The pins can be clicked into place. Rods are available in different lengths and diameters. A rod-to-rod clamp has 2 identical openings in which rods can be placed. The rods can also be clicked into place in the clamp. The clamps can be untightened to allow movement and tightened to finalize the frame construction. For demonstration purposes, construction of an external fixation device is depicted. First, 2 pins are placed at the proximal pole of the fixation area into the tibia, to which 2 rod-to-pin clamps are attached. A rod is then clamped to the rod-to-pin clamps of the proximal pole of the construction. Distally, a long pin is used for insertion through the calcaneus. 2 rod-to-pin clamps are attached to the calcaneal pin. These should be placed at either end, as the pin will pass entirely through the calcaneal bone. On the rod of the proximal construction, a rod-to-rod clamp is placed. A long rod is positioned between the constructions at both poles. Then, another rod-to-rod clamp is placed onto the proximal pole of the construction. A long rod is again placed between both constructions, creating a triangle shape. A rod-to-rod clamp is placed onto the initial long rod. A rod-to-pin clamp is mounted on the pin to be introduced into the first metatarsal bone. These clamps are connected using a short rod. The pin introduced into the first metatarsal bone allows the ankle to be fixated at an angle of 90 degrees. The fixator construction is now complete and is lifted. An animation is used to illustrate how this construction will be placed to externally fixate the tibia, calcaneus, and first metatarsal bone. In an anatomical overlay, the following structures are shown: the tibia and fibula, the calcaneus, and the metatarsal bones. The anteromedial side of the tibia contains safe zones for pin introduction, as anteromedial soft tissue coverage is minimal and there are no hazardous structures located. The tibia and the ankle joint are palpated. 2 pins will be introduced into the tibia, one approximately 10 centimeters proximal from the ankle joint and one approximately 10 centimeters proximal to the first pin. Placement of the first pin is started by incising the skin over a length of approximately 1 centimeter. Next, the subcutaneous tissue is divided using a hemostat until the cortex of the tibia is reached. The drill bit can now be introduced into the tibial cortex. Care must be taken to drill perpendicular to the tibial bone and, in particular, to avoid posterolateral angulation of the drill bit, as this risks damage to the neurovascular bundle containing the anterior tibial artery and vein, and deep fibular nerve. The hemostat is used to retract the skin while the bone is drilled. During the drilling, normal saline is used to prevent excessive heat. After drilling through the second cortex, It is advisable to measure the depth of the drill bit to ensure that the pin will be able to pass through both cortices. This can be done using a depth measurement tool. Next, the pin is introduced. The skin is retracted and kept clear of the pin using a hemostat. The pin should pass through both cortices of the bone and sit so that the tip is just distal to the second cortex. The procedure is repeated to place the second pin. The second pin is introduced approximately 10 centimeters proximal to the first pin. The skin is incised. Subcutaneous tissue split. The tibia pre-drilled. And the pin is introduced. Alternatively, a self-drilling and self-tapping pin can be used. This pin does not require pre-drilling. The safe zone for calcaneal pin introduction lies 1 finger breadth anterior to the posterior border of the heel and 1 finger breadth superior to the plantar surface of the heel. The neurovascular bundle runs posterior to the medial malleolus. The skin is incised at a point 1 centimeter antero-superior to the intersection of the two markings. The soft tissue is dissected and retracted using a hemostat until the level of the calcaneal cortex is reached. A hemostat can be used to retract the skin and soft tissues during pre-drilling. The calcaneus is pre-drilled using the drill. Normal saline can be used to prevent excessive heat during drilling. Ensure that the drill bit has passed through both cortices of the calcaneus. After drilling through the second cortex, it is advisable that the depth of the drill bit is measured to ensure that the pin will be able to pass through both cortices. This can be done using a depth measurement tool. The pin is then introduced into the pre-drilled hole and further introduced using the hand brace drill. The pin should traverse the medullary space to pass through the second cortex of the calcaneus. On the lateral side, the tip of the pin can be identified subcutaneously. This is pointed out using forceps. The skin is now incised to allow the pin to pass entirely through the foot. The calcaneal pin is introduced further. The fourth pin is introduced into the medial side of the first metatarsal bone. The skin is incised, soft tissue dissected and retracted, the first metatarsal bone pre-drilled, and the pin is introduced. Note that to allow optimal healing, pins should not be inserted too close to the bony fracture or areas of soft tissue trauma. Rod to pin clamps are mounted on the tibial pins. It is advised that rods are positioned a minimum of 2 finger breadths superior to the skin. This provides stability while preventing the external hardware from contacting the skin, allowing the skin to be cleaned after completion of the construction. 2 rod-to-pin clamps are mounted on the calcaneal pin, 1 medially and 1 laterally. The 5th rod-to-pin clamp is attached to the pin introduced into the first metatarsal bone. A rod is placed to span the 2 tibial pins. The clamps are secured tightly. Various options are available to connect the short rod to the calcaneal pin. A long rod can be mounted from the central portion of the short rod to the lateral portion of the calcaneal pin, or from the distal portion of the short rod to the lateral portion of the calcaneal pin. Alternatively, it can be placed parallel to the short rod, connecting to the medial portion of the calcaneal pin. In this construction, the long rod is placed running from the distal portion of the short rod to the lateral portion of the calcaneal pin. A rod-to-pin clamp is mounted to the distal tibial pin. A long rod is placed into this clamp and into the clamp on the lateral side of the calcaneal pin. Another long rod is placed parallel to the short rod, running from the proximal pin of the tibia to the medial portion of the calcaneal pin. The clamps are secured tightly. Finally, a rod-to-rod clamp is positioned onto the medial rod and connected to the pin introduced into the first metatarsal bone in order to fixate the ankle joint at 90 degrees. The clamps are secured tightly. Before the fracture is externally fixated, it is first reduced under general anesthesia. The reduction can be assessed using intraoperative radiography. If this is not available, anatomical landmarks should be used to clinically assess the fracture reduction. The frame construction is completed. Depending on the injury, several construction combinations can be built. Sterile gauze swabs are positioned onto the skin around all pins to cover the entry points.